about abdominal pain, basically, there are three types of abdominal pain. There's organic abdominal pain, where we believe that the pain sensations originate in intra-abdominal organs, okay, from a specific disease process. And if you fix the disease process, the pain goes away. Gallbladder pain with stones. You take out the gallbladder, no pain. Acute appendicitis, you get rid of the appendix, no pain. That's organic abdominal pain. Then there's psychogenic abdominal pain, and the patient is experiencing pain from the abdomen, okay? But we don't believe that the pain originates in intra-abdominal organs, okay? Or intra-abdominal nerve endings. These are the people who have pain secondary to chronic stress, psychiatric syndrome, depression, conversion reactions, um, school phobias. And the way you have to treat this pain is to get the patient to recognize that the pain really isn't from intra-abdominal organs or abnormal intra-abdominal processes. It's related to the stress they're experiencing. And then the third one is dysfunctional abdominal pain. And yes, the pain originates intra-abdominally, um, but from normal rather than disordered physiologic processes. All right. So that the problem here is um, the kind of pain we're talking about is menstrual cramps. Okay, ovulation pain, middle shirts. When you eat and pig out, you get pain from overeating. This is basically normal physiological processes. Irritable colon will give you that. That's dysfunctional abdominal pain. So when you're dealing with a patient with abdominal pain, the most important thing obviously is history. History. Okay. Um, you want to know what the onset of the pain was like. What is it? Was it acute or insidious? How long has it been there? Is there any family history of similar symptoms? Did everybody go somewhere, eat in a restaurant, get food poisoning, then everybody in the family has the same type of pain? Okay. Is the pain get better with eating or worse with eating? Okay. The time of day it occurs and the days of the week it occurs. So the kid's having abdominal pain Monday through Friday, but never has a bellyache on the weekend. You know what the cause of this pain is. Okay. It's school. Right. Um, does the pain wake the kid up at night? Any pain that wakes you at night is a problem. On any, we've talked about that throughout this lecture. What's the pain like? Okay. Yes, kid, what's the pain like? It hurts. That's the only answer you're going to get when it comes to kids about that. Okay. How bad is the pain? It's terrible. This is what kids say. But where is the pain? Point with one finger and show me where the pain is. The rule is the closer the pain is to the umbilicus, the least you have to worry because the umbilicus is a convenient place for the kid to shove his finger. So basically, if it's periumbilical, you do not have to worry about it. If it's places further away from the umbilicus, you may have to worry. Okay. Um, what makes the pain worse? What makes the pain better? Are there any other systemic symptoms? Is he having abdominal pain with fever? Does he have abdominal pain and losing weight? Does he have abdominal pain with a rash? These are the things you have to essentially pay attention to. Pets in the house, allergies in the house, any stressful situations. These are the things you have to ask in the history. What's the kid his appetite? The kid's appetite is terrific, but he complains of pain all day long. It's unlikely there's an intra-abdominal um, etiology. What's the activity and the personality of the kid like? Okay. And does the pain interfere with his normal routine? And is he constipated? Those are the questions you have to ask. Okay. Then you do your physical exam and you're going to look at his growth velocity. If he's growing normal, okay, and has been growing normal and has had no weight loss, it's unlikely that this is an organic problem. Okay. Now, when you do the abdominal exam, you do not ask the kid, does this hurt? Because of course he's going to tell you it hurts because that's why he's in the office. So basically, when I'm examining a kid who comes in with current or chronic abdominal pain, I say, I want to listen to your belly, and I want to listen to what the belly tells me about your pain. And I put the stethoscope between two fingers, okay, and I lay my hand on each of them. And while I'm listening, you're palpating at the same time, okay? So basically, you can tell if there's guarding, and if the guarding is voluntary or involuntary guarding, because he or she doesn't think you're palpating the abdomen. They think you're just listening, and you get an idea as to what's going on. Okay. In addition, okay, if you look at the kid's face, if you're about to examine the abdomen and the kid has a look of abject terror on their face, don't touch my belly. Whatever you do, don't touch my belly. I'm in pain. That's the kid you worry about. The kid who's lying on the exam table with their hands behind their back, perfectly relaxed, while you're listening. This kid doesn't have an acute abdomen. There's no problem going on with this kid. Then how do you check for rebound tenderness? Okay? The best way to test for rebound tenderness, and this is over the telephone also when you're worried about acute appendicitis, you tell the kid, get off the table, stand on the stool, and jump off. Okay? If a kid can jump off a stool or jump off a step at home and doesn't double up and roll around on the floor, he doesn't have rebound tenderness. You don't have an acute abdomen. Okay? This is how you diagnose acute abdomen over the phone. My kid's complaining of a bellyache. Okay? He says it hurts a lot. Get him to jump off the step in the house. If he jumps off the step, doesn't double up in pain, you don't have an acute abdomen. You do not have to send this patient to the emergency room. Okay? And then, if necessary, you want to do a rectal exam to see if there's blood in the stool. Okay? Now, we have to differentiate acute from chronic abdominal pain. In infants and toddlers, any kind of pain, both acute and recurrent pain, is a problem. Okay? It should be taken seriously. Infants and children don't lie. Okay? When they go to school, they learn how to lie. That's when they start complaining of belly aches. Okay? So, school age children, dysfunctional abdominal pain is the one that predominates. They're constipated, they have a belly ache. Okay? They overate, they have a belly ache. They have gas, they have a belly ache. Okay? But this is not organic. And when we're talking about adolescents, again, dysfunctional abdominal pain is first. And then second, generally, organic is most likely referable to the GI system or its psychogenic. So you have to differentiate the age of the children when there's a complaint of abdominal pain as well. And then we talk about chronic recurrent abdominal pain, CRAP, crack, because that's what it is. Chronic recurrent abdominal pain is a bunch of crap. Okay? It's a dysfunctional disorder. Up to 20% of children have this. It's generally defined as a complaint of pain occurring monthly for at least 3 consecutive months with a severity that they don't go to school. Okay? That it interrupts routine function. When you ask about chronic recurrent abdominal pain in kids, it's central, very umbilical, and poorly localized. It's described as sharp and unrelenting, but never wakes them up. It's not related to meals, and the kid is over the age of 6. Okay? This is a typical presentation of chronic recurrent abdominal pain. And if you know anything about the kid, or you have a history about the kid, typically this kid is shy, fearing social and intellectual failure. Okay? You've all met this patient. Okay? I've had one who was in high school with me, because you're high school with me, had acute appendicitis before every exam. Okay? And if he got a 95 on the exam, it was a disaster. Okay? And these are the kids who have stress-related, basically, abdominal pain. They generally tolerate new situations poorly, and the family has a high proportion of somatization disorders, alcoholism, and antisocial behavior. So there's emotional problems going on in the family as well. There are no GI findings in these kids. There's no weight loss, there's no diarrhea, there's no fever. And the complaints of these kids may be vague and non-specific, um, not just GI. They also complain of headaches. They also complain of extremity pain. They just have stress-related abdominal pain. Okay, so how do you work these kids up? Okay, we know it's stress-related. Okay, so the more tests you do, the more you can convince him and his family that there's something really wrong with it. So the only workup you do is a urine analysis to rule out urinary tract infection, a SED rate, a CBC, and you are done. That's all you need to do, okay? Because the incidence of organic disease in patients with chronic recurrent abdominal pain is somewhere between 5 and 10%. And of these 5 and 10% of patients, maybe, okay, 50% will be in GU origin. In other words, urinary tract infections, issues like that. So basically, by doing a urine analysis, you got the incidence of organic disease in patients complaining like that down to 2.5 to 5%. So the more tests you do on these people, the more you're going to convince them there's a problem. So basically, you want the treatment is to ensure to reassure the kid and his parents that he is fine. There is nothing terribly wrong with him. Okay, you want to instill a sense of the feeling of normalcy. Okay, that this is normal. There's nothing terribly wrong. The parents should pay more attention to what's causing the complaint, the stressful situation, or what have you, than the complaint of pain itself. And occasionally, if it's significant, or the kid's missing a lot of school, okay, antidepressant medications. Okay, so what are the red flags? Which of the kids do you believe? If the kid has a complaint of abdominal pain every single day for 2 months, 2 or 3 months, and hasn't missed a day of school, that's a red flag. Okay, because this kid is still going to school. This is not school phobia. Okay, if the kid's a C student in school, okay, he's not a high achiever. There's no stress because he got a 90 on an exam instead of 100. He don't care about getting to C in school. If he doesn't care about getting to C in school, he's not going to have school phobias. He's not going to have chronic recurrent abdominal pain. And then obviously is the pain located places other than periumbilical. It's related to food. Okay. It's epigastric in location. There's weight loss. There's vomiting. Bloody diarrhea. These are all the red flags. If there's evidence of other illness like anemia or fever, perianal disease, now we're talking about inflammatory bowel disease, these are the kids you really have to pay attention to. And if the kid is under 6. So those are the red flags that you have to pay attention. Now, very often, chronic recurrent abdominal pain, as the patient gets older, progresses into irritable bowel syndrome. Because 1 in 4 children who've had chronic recurrent abdominal pain go on to develop irritable bowel syndrome. Okay, 75% of visits to the gastroenterologist basically are for these kinds of functional disorders. Okay, so this is a real problem to treat as they get older and they have irritable bowel syndrome. Okay, these patients frequently have sleep deprivation, and if they have sleep deprivation, it worsens the symptoms of the pain. Okay, and very often, irritable bowel syndrome usually follows some sort of infectious GI illness, and then the pain just goes on basically forever. Okay, and interestingly enough, the workup of the GI patients who have irritable bowel syndrome to rule out other organic etiologies is about $6,100. That's a lot of money being spent on GI psychosomatic problems. So basically, you don't do the workup for irritable bowel syndrome unless, okay, there are red flags. For example, if there's evidence of inflammatory disease in the family, like arthritis, Is there a family history of peptic ulcer or celiac disease? If the abdominal pain, the irritable bowel syndrome has pain in the lower right quadrant, there's GI bleeding, and this is obvious, persistent vomiting, nocturnal diarrhea. Okay. Remember when we talked about the young kid who has these diarrhea stools in the morning and never has diarrhea um, at night? If somebody's having diarrhea at night, and it wakes them up, this is an alarm bell that you have to pay attention to. If there's pain with swallowing or difficulty swallowing, again, these are the patients that need a workup. If they're losing weight, if there's delayed growth, delayed puberty, okay, or perianal disease, this is the one that the patients that need the workup. Okay, in order to make the diagnosis of irritable bowel syndrome, you you need abdominal pain at least 4 days a month, and the pain is frequently associated with bowel movements. They frequently have a change in bowel movements, frequently there's increased constipation, or they're developing diarrhea. Um, in children with constipation, once you relieve the constipation, if the pain doesn't go away, then you can diagnose them um, as irritable bowel syndrome. Okay, and again, you have to know what psychologically is going on in the family before you make the diagnosis. Treatments generally are awful. There are really no great treatments for irritable bowel syndrome, particularly in children. Okay. Um, Antispasmodics, there's been only a couple of studies which haven't been very successful. Um, Trimebutane is an antimuscarinic, an opioid antagonist, which they've done a study and it had some good results, 95% approved with it, as opposed to 35 with placebo. Cyproheptadine, I have to like cyproheptadine. Cyproheptadine is an antihistamine, okay? But it works for a lot of other things because of how it works. I use it in kids who may be bordering on anorexia because one of the side effects of cyproheptadine is it increases your appetite. So you give it 30 minutes before meals. It makes these kids eat more who are not quite anorexic, okay? For cold-induced urticaria, it prevents cold-induced urticaria, and it works occasionally in patients with irritable bowel syndrome. Antidepressants, the studies have shown the placebo and the antidepressants work just as well. Antibiotics supposedly treat bacterial overgrowth causing irritable bowel syndrome, okay, are essentially not effective. If the cause of irritable bowel syndrome is lactose intolerance and you cut out the lactose, yes, then it'll work, okay? But lactose is not more common in patients with irritable bowel syndrome than it is in the general population. Food maps is a disaster. Trying to keep a patient on this diet is very difficult. And then there's lots of alternative medicine that have essentially no studies to kids. So if I were you, I'd let the GI people worry about these kids because you're going to get calls all the time about belly. And the last thing we talk about in GI is failure to thrive. Okay? And failure to thrive is a term of a particular problem rather than a diagnosis. Okay? It's a convenient label applied to children whose growth essentially is behind their peers. Often it's associated with poor development and poor cognitive functioning. And it's defined as any kid under the age of 2 who's falling below the 5th percentile on more than one occasion, or whose growth is course of percentile downward. These kids are failing to thrive. The failing to thrive is common in pediatric practice. 5 to 10% of low birth children living in poverty are failing to thrive. Okay, 1 to 5% of all hospitalizations or referrals to children's hospitals are for failure to thrive. And in rural primary care settings, it may be even higher. Now, there's two ideologies for failure to thrive. One is organic, okay? One is they're not getting enough calories in. They're not absorbing the calories that they're getting in. They have excess losses due to diarrhea or chronic vomiting, or they're in a hypermetabolic state, like children with congenital heart disease. They tend to be, because of their heart disease, okay, secreting more epinephrine, increasing their metabolic activity. So they're burning more calories than the normal person. So their losses in general, their losses are higher. So their needs are higher. Or children who just can't, for neurologic reasons, okay, take in the food. They can't swallow. They can't eat. They need tube feedings, okay? All these are organic etiologies for failure to thrive, and most of them are fairly obvious. The inorganic ones are the psychosocial ones, okay? No known medical condition causing the poor growth. So generally, it's due to either poverty or poor parent-child interaction. And it occurs in families with severe stress or with child abuse. So what you need to make the diagnosis is a decent history, okay? You need to know the birth weight and gestational age of the kid. Because if the kid was small for gestational age or had intrauterine growth retardation, let's say the kid weighed 4 pounds at birth, okay, this is your SGA baby. These babies never catch up. So that's the reason they're small. And you have the answer. What's their sequential growth records? Have they been growing normally and then all of a sudden they plateaued out and now they're decreasing their growth? What's the family history and feeding history like? What are the stools like? Do they have diarrhea? Okay. Um, and a review of systems and social history. And then you look at the kids' measurements. Because the first thing to decline in failure to thrive is the child's weight. That's the first thing that causes percentile down. The next thing is their linear growth. And then finally, head circumference. So you have a child who's failing to thrive and the head circumference is decreasing. This has been going on for a long time. This is not something recent, where there's a slow growth of the child's brain. Okay? Look at the kid. Is he funny looking? You know, fetal alcohol syndromes tend not to grow. Um, other congenital abnormalities tend to be small. And then what you do with these kids is we put them in the hospital and we feed them. And if in the hospital we feed them and their growth rate starts to gain weight, then you know the problem is an issue at home, not an organic problem with the child. Or observe the parent feeding the child. Okay? This is how we evaluate patients' failure to thrive. Many of these kids who are failing to thrive are referred to social service agencies who go out to the home, evaluate the home, and see exactly what's going on to give us an idea of the psychosocial factors. Now, what's the workup that we do on a kid that we hospitalize for failure to thrive? Studies, not suggested, on the basis of your initial examination are rarely helpful. You do not do $1 million workup on these kids. Basically, you feed them. Okay, so your initial study should be a CBC, a urine analysis, okay, and urine culture to rule out chronic renal disease as a cause of their failure to thrive. Serum electrolytes, BUN, creatinine, serum calcium, maybe a PPD. That's the extent of the workup that you do. Okay, because there is a diagnostic approach in my handout based on age, and you can put a big bracket around it. You will not see this on any exam. This is there for your reference. Okay, how old is the kid and what the etiology is? And if you looked on the diagnostic approach based on age, for every single age, okay, the first thing on the list is psychosocial. Okay, because that's the most common etiology. Okay, so again, that's there for your reference. I'm not going to quiz you on it. You don't have to worry about it or memorize. Now, other etiologies for failure to thrive is malabsorption syndrome, but that's an organic etiology. A malabsorption syndrome is defined as a failure to digest and absorb dietary nutrients. So malabsorption syndrome basically is a manifestation of a disease than a single specific entity. Okay. Um, and in any patient who has weird dietary habits, vegetarians may fail to thrive, but most vegetarians, okay, really know what they have to do to maintain an adequate diet. Young children, infants and young children shouldn't be on a vegetarian diet, basically because in order to get adequate calories on a vegetarian diet, you have to um, ingest a fairly large volume of food to gain the same calories as calorie dense protein like meats and fish. So again, in young children who are keeping kids on an absolute vegetarian diet may be a problem. Okay, even using plant-based milk, where the protein load of plant-based milk is a lot lower than protein load of cow's milk, may be an issue if they're doing this to very young children. I mean, I once had a patient feeding their infant a Zen macrobiotic diet. Okay, and this kid did not do very well until we screamed bloody murder of this kid. Okay, how do the kids with malabsorption syndrome present? Usually it's diarrhea, steatorrhea. Steatorrhea means large, pale, oily, and foul-smelling stools, growth failure, or any combination of these. Okay, and we talked about these etiologies. Cystic fibrosis is the most common chronic disease causing malabsorption in the United States. And the kid with cystic fibrosis may not present with respiratory disease. It may present with GI symptoms rather than respiratory diseases. Okay? And how do we diagnose cystic fibrosis GI symptoms? Absent of trypsin in the stool and a positive sweat test. Okay? So these kids may have minimal respiratory symptoms and basically early GI complaints. And the newborn screening may pick this up, okay, with that absence of trypsinogen in the blood on the baby. So cystic fibrosis is the cause of failure to thrive. Celiac disease we talked about, okay? Yesterday, last week. Celiac disease is another cause of failure to thrive. And then we have all the general malabsorptive states and defects of digestive absorption function, and you can put a big X around those. You're not going to see it on an exam. It's there for your reference, okay? With, trying to work out what the etiology of failure to thrive could be, okay? And that's the end of GI. And now we go to endocrinology. When I talk about endocrinology, I only talk about three endocrine disorders: thyroid, diabetes, neglectly have growth hormone, uh, short stature. Those are the three we're going to talk about. They used to say that when it comes to all these weird endocrine diseases, okay, the pediatrician reads the textbook once a year because he can't remember them all, and the endocrinologist reads them twice a year because he has to remember them all. Okay, all these endocrinologic defects, they're extremely rare. You're not going to see them, okay, unless you're working in a hospital with an endocrinologist. So we'll talk about the most common. And of the endocrinologic diseases, the first one is the thyroid disease, okay? And I assume you all know the physiology of the thyroid gland. If you took physiology, you ought to assume, but I won't ask you, okay, about it. You know the thyroid gland's main function is to secrete T4, which is thyroxine, and T3, which is triiodothyronine. Okay, um, the embryology with the thyroid gland begins at the back of the tongue, attempts to make its way down into the neck where it belongs. Sometimes it gets stuck, and you have an abnormal placement of the thyroid gland, which may affect thyroid production, T4 production. And the thyroid gland is regulated by pituitary hormone TSH, and that's stimulated by TRH type, the hypothalamic stimulus of secretion, stimulate thyroid production. There's a lot of tests for thyroid. There's free T4, um, total T4. There's free T3, total T3. There's TSH. Okay, if you're working in basic kit for hypothyroidism, you want to do two tests. You want to do a T4 and a TSH. Those really the only things that will give you an initial idea as to what's going on. Okay, TSH basically maintains normal T4 levels. So if your T4 is less than normal and your TSH is greater than 20, you have hypothyroidism. If your T4 is greater than normal and your TSH is less than 0.1, you have hypothyroidism. That's it. That's how you differentiate or make the initial diagnosis. Now, when we talk about hypothyroidism, we talk about congenital and acquired. Okay? So, congenital hypothyroidism, it's as common as Down syndrome, 1 in 4,000 live births. Okay? It's less common in Orientals, Hispanics, and Native Americans. Okay? I mean, more common in Oriental, Hispanics, and Native Americans, less common in African Americans. Okay? It's about 1 in 2,000 Orientals, Hispanics, and African Americans, and 1 in 32,000 African Americans. It's the female to male ratio. Thyroid disease is the only disease where females are more commonly affected. I mean, you've heard me throughout this lecture say it's more common in males than females, except for thyroid disease. Thyroid disease is more common in females. Okay, it's a 2-to-1 ratio, congenital hypothyroidism. When we talk about congenital hypothyroidism, we're talking basically 98% of them are sporadic. Only 2% of congenital hypothyroidism are genetically predetermined. That's number one. And number two, of all the congenital hypothyroidisms you're going to see, okay, 85% of them are thyroid dysgenesis. Okay, that's the most common cause of congenital hypothyroidism. Now, there may be a total aplasia of the thyroid. That's only about a third of them. And then there may be an ectopic thyroid. It may be lingual, subhyoid, or sublingual. And in these, okay, it may function initially. Okay, so the early screen may be negative. Okay, it may present as a mass neck, like a thyroglobulin cyst. Okay, this becomes a problem for surgical removal because if there's a thyroglobulin cyst and you remove it, you're taking out the thyroid gland. Okay, but the majority of patients picked up with newborn screening is going to be for an ectopic thyroid rather than a total aplasia. That's the most common cause of congenital hypothyroidism. A possible cause of congenital hypothyroidism is a mother with thyroid carcinoma who is pregnant and nobody knows she's pregnant, and they give her radioactive iodine to kill the thyroid carcinoma, and of course it destroys the developing thyroid in the baby. But I can tell you that anybody that's going to treat a woman for thyroid carcinoma with radioactive thyroid is going to do a pregnancy test before he gives it to her, but this is a potential problem. Now, genetically, we can talk about defective synthesis of thyroxine. It's 1 in 30 to 50,000 live births. You're not going to see this one. Thyrotropin deficiency, TSH deficiency. Well, if somebody has a TSH deficiency, they're also going to have other pituitary abnormalities or hypothalamic lesions, not just hypothyroidism. So all the things that we list there are very uncommon, except iodine exposure. And why do we talk about iodine exposure? Okay. because number one, iodine is a terrific mucolytic. It's a great cough medicine. And there used to be an iodine containing cough medicine out there, okay, that was used fairly frequently. And if the mother gave the baby this, the mother took this iodine containing cough medicine, okay, while she was pregnant, because it was an over the counter cough medicine, it shouldn't be any problem, okay. Perinatal exposure to iodine um, may result in again suppression of the development of the thyroid gland. But there's another iodine preparation that the mother may be exposed to also. Okay, and what is it? What iodine preparation that we use all the time that a pregnant mother may be exposed to? That,
Iodine salt.
not iodine salts. I said we use in medicine. What do we use in medicine that's an iodine containing product?
Betadine.
Betadine. And if the mother is being bathed regularly in betadine for whatever reason, okay, um, she may absorb the iodine from the betadine, and this may cause a transient abnormality in the newborn, and it may show up as a transient hypothyroidism on the initial screening test, but it's not a true suppression of the baby's basic development of their thyroid. Now, going over the clinical manifestations of hypothyroidism is insane. And the reason it's insane is by the time we make the diagnosis of congenital hypothyroidism on a newborn, they are already brain damaged. And this is why we do newborn screening. And we didn't do newborn screening when I was first a resident. I mean, newborn screening came in after I started my residency. Okay. Then why do we have newborn screening? I mean, the only newborn screening essentially when I started in medicine was screening for PKU, phenylketonuria. That was the only thing we screened for. And then gradually during my residency, the politicians decided that it was cheaper to screen every newborn baby for congenital hypothyroidism than to take care of one intellectually impaired individual for their entire life. So it was a purely economic decision as to why we do newborn screening for hypothyroidism. Okay, because in the days, in the early days when we were looking to diagnose congenital hypothyroidism, it wasn't diagnosed at birth. I mean, the differential diagnosis. If the kid had a large head, okay, and a large anterior fontanelle, and the head was growing larger than normal, then the kid had cerebral myxedema secondary to hypothyroidism, and the damage was already done. Okay, prolonged neonatal jaundice when I started my residency. Any kid whose jaundice was prolonged more than 5 to 7 days, we worked them up to congenital hypothyroidism because we know that that was a potential etiology. Feeding difficulties, lack of interest, okay, respiratory difficulties because their tongue got so large it interfered with respirations, and they were having apneic episodes or noisy breathing. Chronic constipation. Well, we talked about constipation and what it is in babies, okay? Abdominal distension with a large umbilical hernia was common. That was one of the babies I showed you initially in the first lecture. Baby with cold and mild skin, edema of the genitals, slow pulse, heart murmur, and cardiomegaly. Well, it's a little late if the kid has cardiomegaly secondary to hypothyroidism. So I can tell you, okay, that you will know what the kid has congenital hypothyroidism basically within 10 days of their delivery. You're going to get the results from, Albany saying, this kid has congenital hypothyroidism. Repeat the blood tests and start them on treatment. Because you start them on oral levothyroxine, they're fine for their entire lives. Okay? So this is congenital hypothyroidism. Now, what about acquired hypothyroidism? Okay? This appears after the newborn period and after the newborn screening. Okay? It's not very common, 0.0 0.08% of the population. That's about 1 in 1,250 people. And again, more common in females. And of the acquired hypothyroidism, the most common etiology is lymphocytic thyroiditis or Hashimoto's thyroiditis. It's an autoimmune disorder. It's the most common cause of acquired thyroiditis. It's 4 to 7 times more common in females than it is in males. And generally, it shows up after 6 years of age and peaks during adolescence. And the most common presentation of Hashimoto's basically is a goiter. Okay. Other etiologies, polyglandular autoimmune system. Okay, this is an acquired autoimmune endocrine disorder. Irradiation. Yes, irradiation can give you Hashimoto's or acquired thyroiditis. Okay. Do you ever notice what happens when you go to the dentist and they take X-rays? Where does the leather apron come up to? It comes up to here. In the bad old days of the dentist, it only came up to here. So every time you had X-rays in the dental office, okay, they were irradiating the thyroid. And what's even worse, no longer exists, but I can remember this. In the late 40s, early 50s, every shoe store had a fluoroscope. So you can put on a pair of shoes and shove your feet in the fluoroscope and look down and see where your toes fit on the shoes. See, it's a perfect fit, perfect shoes for you. And every time you looked over the fluoroscope to look at your toes, the thyroid was being irradiated. And then suddenly they realized that a lot of rich people were developing acquired hypothyroidism. Why only rich people? Because in those days, you only got one new pair of shoes a year, unless you were rich. If you were rich, you'd get 2 or 3 new pair of shoes a year, and every time you went in, you were irradiated. So no more fluoroscopy in the shoe stores, but this was a cause of acquired hypothyroidism also. And then again, ingestion of iodine medication also can suppress the thyroid. The other thing you have to be aware of, basically, is if you have patients with other autoimmune disease, like diabetes or celiac disease, you have to be on the lookout for acquired hypothyroidism as well, because these autoimmune diseases cross organs. So part of your workup for diabetes or celiac disease may include looking at the thyroid. Another etiology, secondary acquired hypothyroidism, is secondary to pituitary or hypothalamic dysfunction. But if your pituitary hypothalamus isn't functioning properly, you're not just going to have signs and symptoms of hypothyroidism. You're going to have multiple organ system failure. So what's the most common presentation sign of hypothyroidism? The first sign that you're going to see is a decreased growth velocity. As you measure these kids, we said that they start generally after the age of 6, okay? Basically, growth suddenly begins to slow down. That's the first presenting sign, okay? Then they may present with a goiter, and then the other signs and symptoms: obesity, myxedema, cold intolerance, dry, cool skin, delayed bone age, and delayed dentition. Okay, delayed eruption of the baby teeth. If they're 6 years old and they still have all their baby teeth, alarm bells should begin to go off that maybe these kids are hypothyroid. Thinning of the hair, lethargy, constipation, and delayed puberty in adolescence and adolescence. These are the signs of acquired hypothyroidism. Okay. Then we have hyperthyroidism. Okay, congenital and acquired. Congenital hyperthyroidism is a disaster. It's neonatal thyrotoxicosis, and this is a big problem. Basically, it only occurs, okay, in mothers with Graves' disease. Okay, almost exclusively in mothers who already have hypothyroidism. Okay, Um, and it may be transient or it may be prolonged. It's not every baby born to mothers with Graves' disease, only about 2% of them. But these kids are a disaster, and it's the only thyroid disease that's equal in both males and females. And we don't know why it occurs. We don't know why those infants of mothers who have Graves' disease, okay, are developing uh, neonatal thyrotoxicosis. But these kids are a mess. They're born prematurely or extreme lowly birth weight. They're microcephalic. They're irritable. They're hyperactive. They eat like crazy and they still do not gain weight. Okay. They're tachycardic and tachypneic. They have prominent widespread eyes with exophthalmos. Their fever is elevated and their goiter that's there may be so large it may compromise their respiration. And somewhere between 15 and 25% of these patients go into cardiac failure. These patients are a real mess. They go straight to the NICU and we poison their thyroid. Okay, basically we give them either Google solution or propylthiouracil as treatment. Okay, and hopefully they do better, but their prognosis is really dark. They have premature cranial synostosis. Okay, they have neurodevelopmental defects and intellectual um, impairment. So fortunately, it's not very common. Okay, um, when you see these kids, but it becomes a mess. Acquired hypothyroidism, Graves' disease, okay, is the most common form of acquired hyperthyroidism. It's an autoimmune disorder, and it really doesn't occur in children. Okay, it's 0.02% of children. 1 in 5,000 kids may develop acquired hypothyroidism. Okay, again, more common in females than males. Okay, and most of the patients who develop acquired hypothyroidism, there's a positive family history of some autoimmune thyroidism. So, what are the clinical manifestations? Okay, what they teach you in adult medicine about hypothyroidism is not seen in children. Okay, they teach you goiter, thyroid enlargement, exophthalmos, and pretibial myxedema. This does not occur in kids, okay, at all. Okay, basically, if a kid is going to develop hypothyroidism, okay, number one, the onset is not fulminant as it is in adults. It's slow and insidious, okay, and basically the interval between the onset of hypothyroidism, okay, and you making the diagnosis is as long as a year. So it's not an easy diagnosis to make, okay? And in prepubertal children, it's even longer. Now, the peak incidence of hyperthyroidism is not prepubertal children. Generally, it's in females between the age of 11 and 15. This is the case. If they're going to present with Graves' disease, this is the time when it may start, okay? So, what are the initial presentations, okay? The initial presentations, the earliest sign is emotional disturbances, hyperactivity, irritability, excitability, and crying easily. And I have just described every 11 to 15-year-old female. Okay? Every 11 to 15-year-old female, that's how they are. Okay? So they all definitely do not have Graves' disease, but that's how the kids with Graves' disease are going to present. Okay? They may develop a goiter, but it's usually very small. Okay? Um, and the other physical findings, other than the emotional ones I just described, is they may develop a tachycardia, insomnia, and fatigue. So maybe if you have an adolescent girl who, when you examine them, are tachycardic, they develop a fine tremor. Okay, they maybe have insomnia or fatigue. Okay, you may be concerned about them probably developing hypothyroidism. 1/3 may develop proptosis of the eyelids. Okay, that's a possibility. These kids eat like crazy and complain they cannot gain weight. Okay, they may have heat intolerance, increased sweating. They develop proximal muscle weakness. If you're doing a physical exam and you suspect it, that's what you look for. Their menses may be delayed. Okay. And any kid under the age of 10 who has been toilet trained and never wet the bed, and suddenly you got an 8 or 9 year old who's wetting the bed again, that's included in your differential diagnosis. It's sudden onset of enuresis in somebody who has never had it before. That's an alarm bell that goes off. Okay. They may develop neurocognitive deficits and attention deficit disorders. I mean, this is basically the differential. Their growth velocity may be increased, their stool frequency may be increased. But again, the initial presentation is not like the adults. Okay. And the initial physical findings that you're going to is tachycardia, tremors, insomnia. Okay. And obviously, we talked about the laboratory test. The T4 is increased, and the TSH is so TSH levels are lower. So that's thyroid disease. Okay, now, I mean, the treatment for thyroid disease basically is medical poisoning with propylthiouracil, uracil, or methamox, methamphetamine. I mean, uh, tapazole, or surgical removal of fat. Now we switch to diabetes. And when we switch to diabetes, we're going to talk about type 2 diabetes. And when I first started this lecture, this series, 38 years ago, I would say type 2 diabetes, adult onset, we do not have to worry about in kids. Unfortunately, that is no longer true. Okay. For the past 10 to 15 years, type 2 diabetes is the new epidemic in the pediatric population. Okay. The peak presentation of type 2 diabetes now is between 10 and 15 years of age. This is becoming a major problem. It's more common to see in African Americans. Forget about it. It's commonly seen in every ethnic group now. We're not just seeing them in certain specific racial groups. I had one kid, he was 15 years old. He was 5 feet 4 inches and weighed 290. His BMI was 3 standard deviations above the 90th percentile. Okay, this was a big problem. Okay, and basically, the triggers of why we're seeing it is that it's aggravated by environmental factors like decreased physical activity, sitting on your butt in front of a screen all day long, or the hypercaloric lipid-rich diet. Now, unlike type 1 diabetes, in which the pancreas is being destroyed, okay, the problem here is insulin resistance. Insulin resistance of the skeletal muscle. Okay, now, the issue is insulin resistance is a normal state in adolescence. When somebody becomes an adolescent, they normally have some degree of insulin resistance. Okay? But insulin resistance becomes worse with obesity, inactivity, acute illness with the release of stress hormones. Okay? These all contribute further to the insulin resistance. So, if you have insulin resistance, it means the glucose is not getting into the skeletal muscle. So if the glucose is not getting into the skeletal muscle, where is it? It's hyperglycemia. Okay? If it ain't going into the muscles, it's staying in the bloodstream. Now you have hyperglycemia. Okay? So you have hyperglycemia, the pancreas reacts by secreting more insulin to try and get the sugar into the cells, which are complaining they don't have enough glucose. Now, here's the problem. Chronic hyperglycemia has a deleterious effect on the islet cells of the pancreas. Okay? In addition, these kids are not just hyperglycemic, they also have hyperlipidemia secondary to their lipid-rich diet. And chronic hyperlipidemia also has a deleterious effect on the beta cells of the pancreas. So you see the cycle that we're setting up here? Okay? You get obese, you have a hyperlipid-rich diet, you're hyperglycemic, and that both of those gradually destroys the pancreas. And because you have decrease in beta cell functioning due to hyperglycemia and hyperlipidemia, okay, your insulin secretion stops working, and now you have type 2 diabetes. What these patients don't have, unlike type 1 diabetes, is these patients do not have basically anti insulin antibodies. They don't have anti-insulin, anti-GAD, and anti-IA2 antibodies. You're screening a patient for type 1 diabetes, you run these tests. If you're screening somebody for type 2 diabetes, it's a waste of money. You don't even look for them because that's not the cause of their diabetes, unlike type 1 diabetes, which is an autoimmune disease, and you have these elevated antibodies. You don't have them in type 1 and type 2 diabetes. The only time you might do these antibody tests is if a patient with type 2 diabetes presents with ketoacidosis. Generally, they don't present with ketoacidosis, but if they do, then maybe you want to do a blood test. Otherwise, it's not necessary. So how do these kids present? Okay, usually they are obese and hypertensive, and they're prepubertal. 95% of patients with type 2 diabetes are morbidly obese and prepubertal at the time or right before their diagnosis. They have acanthosis nigricans, and you know what acanthosis nigricans looks like, right? Okay. This is not a sign of type 2 diabetes. This is a sign of insulin resistance. This is usually the first sign in the morbidly obese patient that they have significant insulin resistance. They may not have type 2 diabetes yet. They may not get there. They're not at that point yet. Okay. Other signs of insulin excess, again, dyslipidemia, hypertension, 1/3 of all patients, okay, are hypertensive, okay, and maybe polycystic ovary disease, okay. So this is the physical findings. So who do you screen? You're going to screen everybody who's morbidly obese. I mean, my notes say, yeah, you want to screen people who have a positive family history of type 2 diabetes and a primary or secondary family member or relative. Forget about it. There's no ethnic group anymore. There's no type 2 family. If they're morbidly obese, you want to screen them. A recent study came out and said soda and fruit juices in boys, and it doesn't work in girls, and don't ask me why. It doesn't work in boys, okay? But every 8-ounce serving of soda or juice, okay, in a kid, okay, during childhood, is associated with a 34% increase in insulin resistance by the time they're teenagers. Every single 8-ounce serving of juice or soda. So this is why we don't give kids juice. Okay, the more sugary drinks a kid drank before they became a pre-teenager, okay, the greater their insulin resistance and muscle fat in the liver. So we want to stay away from soda and fruit juices in these kids. Okay, it is a problem. So how do we work these kids up? What the heck can we do? Okay, and what are the problems? Okay, well, basically, before a kid develops type 2 diabetes, okay, here's where you really want to start the treatment, okay? You know, they have what we call the metabolic syndrome. And another name for the metabolic syndrome is the insulin resistance syndrome. These kids are showing sign of insulin resistance without being a diabetic, okay? And this is where you really want to break into the cycle. Because currently, one in five children and teenagers were obese between 2021 and 2023. Part of it had to do with the COVID epidemic, but I mean, that's 20% of all kids in the United States are significantly obese. We're talking about a major epidemic here, okay? So, your workup on any kid with metabolic syndrome, again, is to look for things like a fasting blood sugar, serum lipids, okay, um, to see what's going on. All right. And there's one thing we'll talk about, which is a major problem for these kids even before they become a diabetic. So when we talk about metabolic syndrome, okay, one of the co-occurrences of cardiovascular factors, because these are kids are going to be at risk for cardiovascular disease. Number one, they have abdominal obesity, central obesity. Okay, they're already developing atherogenic dyslipidemia. Their blood pressure will be elevated. They have a high fasting blood sugar. They're in a pro-inflammatory state. They're in a prothrombic state, which means these kids are already beginning to narrow down their coronary arteries. Okay, and it has been shown, okay, that these kids, even before they get type 2 diabetes, are showing measurable cognitive changes in brain structure and cognitive function. They have more cerebral spinal fluid than they have. The amount of cerebral spinal fluid is going up, and the volume of their brain is going down, and suddenly they're starting to do worse on cognitive functioning like math and spelling scores. It's involving their cognitive functioning. Even before they have type 2 diabetes, this metabolic syndrome is a disaster. Okay? So, how do we diagnose? When do we label a kid with metabolic syndrome? Okay? Any three of the following. Okay? Increased blood pressure, more than 90% for age, sex, and height. Increased triglycerides greater than 150. Decreased HDLs lower than 40. Okay? Abnormal glucose, the blood sugar greater than 100. Waist circumference. Okay? You measure the kid's waist, and the way it's supposed to be done is you measure the waist circumference at the highest iliac crest. You take 3 measurements, you average them, and then there are tables for what's normal abdominal girth for basically ethnic groups in the country they're living in. Okay? These are any three of these, and you have metabolic syndrome. Now, what causes metabolic syndrome? Basically, it's overeating. And what are the two basic hormones that are responsible for appetite? Leptin and ghrelin. Okay, leptin says I'm full. Ghrelin is the gremlin. That's the one that says feed me, feed me, feed me, feed me. Okay. The problem is what's happened in the past 150 years. Okay. The first big problem, okay, is the increase in the number of ultra-processed fast foods, highly lipid, highly caloric foods. That's number one. Number two, the light bulb. The light bulb means you could stay up later. Okay? Now you have televisions and your cell phones, which also means you can stay up later. And when you become sleep deprived, okay, The problem with sleep deprivation, okay, and we're talking about less than 4.5 hours sleep a night. Sleep deprivation leads to the secretion of endocannabinoids. Okay, and endocannabinoids make you more hungry. And when you're more hungry, what's the easiest thing to cure your hunger? Carbs. Okay, snacks, ultra processed crap. Okay, and this becomes a big problem. Okay, and when I'm talking to adolescents, right, about their weight and their eating issues, I can tell you that every adolescent in high school will tell you the same thing. The first question I ask, I know the answers even when I ask the questions, do you eat breakfast? And the answer is no. Breakfast makes me sick to my stomach. I'm not going to eat breakfast. Do you eat lunch in school? Oh, God, that stuff is awful. I don't eat lunch in school either. So guess what? They come home at 3 o'clock in the afternoon after fasting for 16 to 18 hours because they haven't eaten anything since the night before, and they are starving. And they eat everything that's not nailed down. And what's the easiest thing to eat, okay, is fast foods. And this is the cycle that gets set up. Okay. Now, when I'm talking to them about their crazy eating things, okay, I say to them, listen, I'm concerned about your weight, and I'm only going to ask you to do one thing because we have a thing in medicine called KISS. You know what the KISS stands for? Keep it simple, stupid. That's what KISS stands for. And I write it on the exam paper, big letters, KISS. Keep it simple, stupid. I am not going to give you a whole list of things you can do. I'm going to ask you to do one thing. And the one thing I'm going to ask you to do is eat breakfast. And I'm going to ask you to eat protein for breakfast. I don't care if you eat chicken. I don't care if you eat steak. I don't care if you eat eggs. You're eating protein for breakfast. Because if you think about the most foods that we eat for breakfast are carbs. Okay? And if I can get a kid to do that, okay, he will start to lose weight. Okay? And I mean, I lost 40 pounds and took 4 inches off my waist by doing one thing: stop eating Cheerios for breakfast. My breakfast used to be fresh fruit, Cheerios with blueberries, and coffee. That was my breakfast every morning. Okay. And when I got to the office, and I eat breakfast at 6:30 in the morning, so when I got to the office at 10 o'clock in the morning, I was starving. Because I ate carbs for breakfast. So then you go across and get a bagel with cream cheese, and another cup of coffee, more carbs. Okay. So I stopped eating Cheerios. Basically, my breakfast now is the same fruit, half a cup of nuts, a protein bar, and coffee. I eat that at 6:30 in the morning, and I'm not hungry till dinner at 6:30, 7 o'clock. Basically, that's what it is. Okay. So I took off 4 inches from my waist, and I lost 40 pounds. Okay. Just by doing that. If I can get a kid to do that, I'm not going to tell him he has to exercise, how much exercise he has to do, etc. I just want him to eat breakfast. And if he eats breakfast, I'm breaking into the carb cycle. Okay. And I'm breaking into the hunger cycle. And once I can get a kid to do that, I, won the battle. Okay. Because basically, if we talk about it, okay, you know, these kids are up all night on their phones. Okay. They're not getting enough sleep. Their body is secreting the endocannabinoids, which is increasing their hunger, which is increasing ghrelin. And we have to shut off ghrelin on these kids. And if we can do it, and it takes years. I mean, it doesn't happen overnight. I mean, every time they come in, they're 11, they're 12, they're 13. I'm yelling at them. Finally, at 15, they come in and they've lost 40 pounds. What happened? Oh, I started eating breakfast. So, I drill it into their head every time they come, and I tell them why I'm worried about it. Okay? Because you can't change your genes, and you can't change your microbiome. Okay? These are predetermined. Okay? If in fact, even in utero, If you were under, if you were LGA or SGA, that's going to affect your eating patterns also. Okay. And preemies and low birth rate babies get fed high calories very often. The mothers feed them, because they're premature. We got to fatten them up like the Christmas turkey or goose. Okay. And they develop central abdominal obesity. And then that's something that we can't get rid of. Okay. And so basically, long term central obesity increases their risk for insulin resistance as they get older. So, a lot of these things predetermine what we wind up to when we get to um, early adulthood and obesity. All right. So you can't put a patient on a diet because what happens if you go on a starvation diet? What is your body doing? It's secreting ghrelin. Feed me, feed me, feed me. Okay. It's very hard to stay on a starvation diet when your hormones are telling you to do something entirely different. So we have to instill good eating habits, not calorie reduction. Okay? Eating more protein. Because if you eat more protein, all right, and your body is asking for carbs, where does the body get the carbs from if you're not eating it? From the breakdown of your fat. That's your carbohydrate stores. That's the way we want to get dieting done. The new drugs that are out there now, okay? The GL1, what are they? Are they fat burners? No. Basically, they suppress your appetite. That's what they do, okay? And the problem is so great now that this kid I told you about, this 15-year-old pain in the ass who sits on his butt and doesn't want to do exercise. And, in the middle of the snow, we had this winter because I started them last August on GLP-1s because they are now approved for kids down to the age of 12. Okay. I said, go out and shovel the snow, make some money. I don't care if he makes some money. I want him to do the activity. Even without the activity, I saw him last week. Okay, he's finally starting to exercise. Took me 10 months of screaming. But even without, I didn't scream at him. We had conversations. But even without the exercise, he lost 45 pounds in 10 months on the GLP-1 inhibitor. He probably could have lost 80 pounds. Okay, because you can lose 5 to 10 pounds a month on this stuff if you're that obese and you don't eat and you exercise. So he finally started to exercise, and hopefully he'll continue. But the problem is so bad that they're talking about bariatric surgery on teenagers. Okay, and let me tell you, bariatric surgery is no panacea. Okay, I had no more patients. I had one family, 5 boys. Every boy was morbidly obese. I mean, morbidly obese, a 5-year-old weighing 110 pounds. I mean, these kids were morbidly obese. Okay. And they moved to New Jersey, and the older kid who weighed close to 300 pounds wanted to play football. Of course, they wanted to play football. You put a 300-pounder on the line, nobody's going to run past them. Unfortunately, he was hypertensive, so we wouldn't clear him. Okay. These kids were morbidly obese. Both parents had gastric bypass surgery. Okay, gastric sleeves, I guess. They both had gastric sleeves. Both parents had gastric sleeves. You would think they would do something to their kids rather than letting them get this way. But guess what? They were both morbidly obese also, even though they had the gastric sleeves on, because they figured out how to bypass the gastric sleeve and take excessive calories. So even those are basically, you know, basically not panaceas. And this is what they're talking about on teenagers. Okay. Now, here's the big problem. Okay. Not only are these kids at risk for developing type 2 diabetes, they're at risk for developing non-alcoholic cirrhosis of the liver secondary to the chronic hyperlipidemia. And I can tell you, when I screen kids for morbid obesity, not only do I look for their lipid profiles, okay, I do a hepatic screen because these kids already have elevations of their liver enzymes. They already are having inflammation of their livers secondary to their obesity. So this is a major problem. Okay. So and how do you treat these kids? Well, if they shift into um, type 2 diabetes, where now they have an elevated blood sugar, an elevated postprandial blood sugar, okay, they have all the other hypertensive, all the other signs of type 2 diabetes, um, and their blood sugar basically is greater than 300. If you can get them to lose weight, you will cure their type 2 diabetes. If you can't get them to lose weight, then you have to treat them as a type 1 diabetic with insulin. I know that they've been using metformin to treat these patients with type 2 diabetes and morbid obesity, but metformin has terrible side effects and the patients don't like taking it. So the new treatments are going to be GLP-1s for all these kids who have this. And you do the same screening and everything else as a type 1 diabetic when they finally develop this type 2 diabetes. Now, type 1 diabetes is very different. Type 1 diabetes, juvenile onset, insulin dependent diabetes, is a lot less common. Okay. We're talking about 2 per 1,000 children, not 20% of kids who are morbidly obese. Okay. Its onset occurs predominantly in childhood, usually somewhere between 5 and 7, the onset of school, and then in adolescence, the onset of puberty. Okay, we know there's a genetic susceptibility, okay, but there are some environmental factors that also contribute. Okay, obviously, if they have other associated autoimmune disorders, like we talked about, like celiac disease or hypothyroidism, thyroiditis, and multiple sclerosis and Addison's disease. There's an increase of type 1 diabetes in these kids as well. Okay. And then the environmental factors involved. And the biggest environmental factor involved is viral illnesses. We know that, for example, Coxsackie B3 and B4 destroy islet cells if you get this infection. Cytomegalic virus can do it. Rubella and mumps as well can do it. They are both known to infect beta cells. And during COVID, I saw more type 1 diabetics in those 2 years than I saw in the 10 years before. Okay? So these were in kids who had COVID. These were in families. We don't need the immunization of a kid. COVID is no big deal. You know, the COVID vaccine has all these terrible side effects. I mean, you wouldn't believe what parents told me. It makes you stick to the refrigerator. Okay? It makes you stick to metal. You know, when they told me that, I asked the excrements from their noses. But basically, I believed at that time that the COVID virus, coronavirus, was destroying islet cells. There was no way I could see that many diabetics than I had seen in the previous years in those 2 years. I mean, and previous tests proved me right. Okay, they did. I mean, previous studies that they did, kids who had COVID were at greater risk of developing type 1 diabetes than kids who didn't have COVID. So my experience was right. I mean, this was just seeing them. Okay. And basically, type 1 diabetes usually occurs with greater frequency in the autumn and winter, and that's basically because the risk of infections go up. Okay. There have been some chromosomal loci have been identified, making people susceptible to diabetes, but not as there's been no true gene identified that leads you to develop type 1 diabetes. So pathogenesis, okay? You get an autoimmune process. Something happens that destroys pancreatic islet cells, whether it's this infection in genetically predisposed individuals, we don't know, but your islet cells are being destroyed, which means You don't develop symptoms right away. It's a gradual progression, and the symptoms don't show up until 80 to 90% of the beta cells are destroyed. Then you begin to show the symptoms of diabetes. Okay? So the first thing that happens is you have an insulin deficiency, inadequate insulin production if you don't have enough islet cells. So if you don't have enough insulin, okay, glucose is not getting into the skeletal muscle. So if glucose is not getting into the skeletal muscle, that's why we have an elevation of postprandial hyperglycemia. Well, if the skeletal muscle isn't getting enough glucose and the body is demanding it, you suddenly have breakdown of fats. Okay, because skeletal muscle said, I need more and more glucose and I'm not getting it. So suddenly you start breaking down fats, and now you start developing ketosis. Okay, and when you start developing ketosis with prolonged insulin deficiency, the liver gets involved. And the liver starts producing even more glucose through glycogenolysis and gluconeogenesis. And now your fasting blood sugar goes up. So the first thing that goes up physiologically, your postprandial, and then you have chronic insulin deficiency. Now your fasting blood sugar goes up. Now, when your fasting blood sugar goes up, okay, now you have all this glucose in your blood, you're going to get rid of it. And where do you get rid of all this extra glucose? In the urine. So you develop glycosuria. But if you're excreting glycosuria, okay, what's going along with the glucose? Fluid. So now you have polyuria. And because you're excreting all these fluid and electrolytes, you're getting dehydrated. So you drink more. So you get polydipsia. And of course, eating more. So you get polyphagia. This is the process of the physiologic process of how you develop basically type 1 diabetes. Okay. And then what happens is because you're dehydrated, you're urinating a lot, okay, you're using electrolytes, okay, you're developing chronic stress. And boy, your stress hormones do a great job of making the diabetes worse. Because insulin secretion is further impaired by epinephrine, which is a stress hormone. So the stress hormone impairs the secretion of insulin. Okay. Epinephrine, cortisol, and growth hormone also antagonize the action of any insulin that you have around. Okay. And then we talked about glycogenolysis and gluconeogenesis. That's enhanced once again by glucagon, epinephrine, growth hormone, and cortisol. Okay. So this goes on to make the process even worse and makes the hyperglycemia even worse. Now, the polyuria, polydipsia, and polyphagia, okay, is often usually about 1 month prior to diagnosis. And I can tell you that I've rarely diagnosed diabetes in pediatric patients by those symptoms. I had one 12-year-old girl, okay, the mother calls me up and says to me, my kid is urinating a lot, drinking a lot, and eating a lot. And by the way, her blood sugar is 120, so I think she's got diabetes. I said, excuse me? She said, my husband has diabetes. I recognized all the signs. I tested her blood sugar, and that was it. So I didn't make the diagnosis, the mother did. Okay? Most kids, okay, don't come in. We don't do routine blood sugars on every kid who comes in. So you're not going to get a fasting blood sugar. You're not going to get a postprandial blood sugar. I mean, if I send the patient to the lab for, a blood test for a metabolic profile, okay, and the blood sugar comes back elevated, I may find a kid with an elevated blood sugar, okay, and half the time they didn't go to have their blood drawn. They ate breakfast before they went. So again, it's not inaccurate. So usually the majority of the kids I've diagnosed with diabetes come in ketoacidosis. They come in sick, weight loss, lethargic. I had one How old is she? Less than 16 years old. And one 16-year-old patient got carried into the office with a 20-pound weight loss in 10 days. And I know she had a 20-pound weight loss in 10 days because I saw her 10 days ago and I knew what she weighed 10 days ago. And now all of a sudden she's in diabetic ketoacidosis. Okay. She's now fine, 2 kids on her own. The diabetes is well controlled, no problem. And that's how she got carried in. One other teenager, I did a routine urine on her, totally asymptomatic, routine urine, 3+ sugar in the urine. Okay, she was a diabetic. Okay, but most of the kids who come in ketoacidosis. So what? How do we define ketoacidosis? Ketoacidosis is hyperglycemia, blood sugar usually greater than 300. They have ketonemia, elevated ketones in their blood. Okay, they're acidotic, their pH is below 7.3. Okay, and they can have glycosuria and ketonuria. And usually there was something that predisposed them to this, that threw them over the edge. Usually some sort of stressful situation. They got the flu, they got sick, something happened to them that threw them over the edge. Okay, and basically that's how they present. Now that there's a rare presentation of non-ketotic hyperosmotic cold. And here's another one. I said this only occurs in adults. These are people with blood sugars greater than 800. They don't have ketosis, and the reason they don't have ketosis is the hyperosmolarity suppresses insulin production, and there's a mortality of high of 70% of these people, but we don't see it in kids. And I've improved long because I made these wonderful assertions. One of my residents, when I was a chief resident, became the head of the pediatric ICU at Kings County Hospital, and she told me that neurologically impaired children may come into the hospital. They're seeing them in the hospital with hyperosmotic coma. Okay, so if they're non-ketotic, they come in hyperosmotic coma and their blood sugars are above 800. So it can occur in children, and basically it occurs in intellectually impaired kids. This is neurologically impaired kids. Okay, so I used to give a lecture. So happy I know. Fluid and electrolyte treatment of diabetic ketoacidosis, but they changed the rules. Okay, and the way they changed the rules is, okay, when the patient comes in diabetic ketoacidosis, you want to do three things. Expand the intravascular volume because they're all dehydrated. Okay, correct deficits of fluid, electrolytes, and acid base, and give them insulin. Those are the three things you do. Okay, so fluid management. You calculate their fluid maintenance. All that have calculate fluid maintenance based on weight, and you give them 2.5 times their fluid maintenance. That's it. Give them 2.5 times their fluid maintenance. You don't have to calculate anything else. You give them that much fluid, and basically, if you rehydrate them, and they're basically well, their acid base and electrolytes will improve. Okay, you give them half normal to normal saline, and everything else will improve, and then you start them on insulin. Okay, now if they're urinating, you add potassium to the IV. Most of them are urinating, they're not in shock, so you add potassium. Why the heck do we add potassium to the IV fluid? What do you need potassium for? Okay, you need potassium because insulin and glucose does not go into the cell unless there's potassium present. You need potassium and I don't know why it happens, but you need potassium as well as glucose and insulin to get the glucose into the cells. And in the bad old days, okay, when I was a resident, we had lots of kids who came into the ICU, post cardiac arrest. Okay, they came into the ICU in BPAC. If you got their EKG, that's how they came in BPAC. They were post cardiac arrest. They were hyperkalemic. because when you have tissue damage in a wrist, you have cell damage, the potassium goes up. We would push an IV solution of 50% D5, 50% glucose, and insulin. We give it to them by IV push, okay? Because this was caused by hyperkalemia. I used to have rhythm strips. I don't know what that might happen to them. They disappear. But what it would happen to them, you watch the EKG, the tech would get slower and slower, and then all of a sudden, you get a normal EKG just by pushing glucose and insulin. Because glucose and insulin needs potassium. And if you gave them a lot of glucose by IV push, it took a lot of potassium from the vascular system and put it back into the cells, and the VPAC went away. So you have to add potassium to the IV fluids in order, that's why we add potassium. Okay? And then basically we give insulin, and the amount of insulin we give them is 0.1 unit per kilo IV push, and then there's 0.1 unit of insulin per hour, per kilo per hour, till the blood sugar returns to normal. Now, we're giving a lot of fluid, okay? We're giving them insulin. We're dropping their blood sugar. Remember, their blood sugar is 300 or more, okay? We're dropping their blood sugars. We're giving them a lot of fluid. What do we have to worry about? What? Hypoglycemia? Hypoglycemia is not really the problem. I mean, the blood sugar gets lowered fairly rapidly, but where isn't it getting lowered as rapidly? In the brain. Remember, we talked about hypernatremia? Well, hyperglycemia is the exact same thing. So as you're treating these kids for their hyperglycemia, you have to look out for CNS issues, okay? Headaches, okay? Changes in consciousness and respirations, bradycardia, apnea, pupillary changes, papilledema. You have to monitor these kids. You just can't watch, okay, we're going to go eat lunch, and that's it. We're not going to worry about it because these changes may occur, and you may have to reduce the iron. Now, I am not going into the treatment of diabetes, okay? Because basically what's going on now with the treatment of diabetes is unbelievable, okay? Remember, when I was a resident, we didn't have dextro sticks, okay? We treated patients by monitoring their urines rather than their dextro sticks, okay? Now the treatment of diabetes, okay, is they all wear a Dexcom. You know what a Dexcom is? And the young kids have insulin pumps. And the Dexcom talks to the insulin pump, okay? When I was a resident, we were only two insulins, regular and NPH. We didn't have any of the long-acting insulins either, okay? So the Dexcom talks to the pump. If the kid becomes hypoglycemic, the pump slows down, okay? So this is remarkable now what's going on, and I know nothing about it, okay? I freely admit it. This goes to the endocrinologist or the diabetologist who treats these kids. And, you know, what's a normal hemoglobin A1C? Right? Anybody know? Okay. Normal hemoglobin A1C is around 5, 5.5. That's the normal hemoglobin A1C, right? But in diabetics, they want to keep the hemoglobin A1C down below 7.5. There was a point where they used to say, well, young children won't recognize signs of hypoglycemia, so we should allow the hemoglobin A1Cs to be higher between 7.5 and 8.5, okay? And then it became a problem because they found that with these kids, with hemoglobins that high, they were already developing renal problems and chronic changes. So we're not doing that again. Everybody has to be down below 7.5, and now with the pumps, they're achieving it. Okay, so my job has nothing to do with insulin and insulin management. That's the job of diabetics. But what I really want to do is when I see these kids, okay, and talk about it, it's basically encourage exercise because exercising these kids will improve their management, okay? make sure that somebody did, and diabetologists do this, rule out hypothyroidism, celiac disease, and if they're losing weight or not gaining weight, celiac disease, okay, um, or hypothyroidism. This is what you really want to look at, monitor their blood pressures every time they come to the office. And the one other thing that you really want to deal with that I don't know if I acknowledge is what's going on in the family. Okay? Because if there's more than one kid in the family and one's diabetic and the other's not, why can't we have candy? Why can't we have pretzels? Why can't we have all these carbs? And there's stress relations going on in the family as well that somebody should be aware of, with the dietary management of these diabetics. Now, the pumps and Dexcoms are miraculous. Okay, new treatments for diabetes besides the pumps. Okay, are things like islet cell transplants, oral insulin. Now for adults with insulin who don't have pumps, everything's pre-measured. I mean, they give themselves their own shots without an issue. I mean, the management of diabetes is getting better and better. And the last thing I read about, this is purely research at the moment, but in your generation, you will probably see this, okay? They are working on a stem cell approach, okay, giving engineered allogenic insulin producing cells. Well, that's pancreatic transplants, right? Okay, or pancreatic transplants. But if you transplant a pancreas, you have to immunosuppress the patient. Because you're giving a transplant, they are trying and they're working on now to develop these allogenic insulin producing cells where you do not have to use immunosuppression, where these cells are basically not required to have chronic immunosuppression, where the cells do not trigger an immune response. And boy, if they can do that, it's all over. Insulin is cured. Okay? And I don't doubt somewhere down the line that this is possible. If you consider the past 50 years, we went from no dextrose sticks and monitoring diabetics by the urine to insulin pumps that talk to one another. That's only been in 50 years, 50 or 60 years. So you may see this, okay, in the scheme of things, okay, if you're in medicine that long. Right, I'm going to stop here, take 15, 20 minutes or so, okay, and when I come back, okay, we're going to talk about basically short stature and then death and dying. And you have a lecture after me?
Yeah.
You'll have a long break after the lecture after me. So take a break and we'll come back and talk about those. Can I destroy your webinar? Can I destroy your webinar?
Wait.
Going into 11. No, Dave. He's the one that had drugs so hard. Yeah, wait. Oh my god. No, it's not you. It's not you. You got it wrong. I don't basically want to try whatever. And it just
Wait, actually.
okay, on the water.
Oh,
Yeah.
interesting.
Yeah. Yeah.
And I was like, because she's on a type of
How'd she go?
How'd she know what? Oh, so it's not like, I texted her like, early on, she was like, wait, I'm not gonna test for nothing. That's fine, I was like, no, it's gonna be positive. And you got, I was like, yeah, so he was still getting to a part.
Yeah, and it goes like 50 yeah, because like he would. Like there's still other music. Yeah. And yeah, I don't know, like my parents don't love it. Like they would all day. Or like the whole time. Fine with that. I mean, no, it's a minute. It's a minute. And so it's like things like that. Let me like my ears are like oh no, I want to all like oh I want to know yeah you're right like 5 oh yeah you do wait how many quotes 5 no what oh well oh no you had, oh no you had you had 8 before it's like I only got more like yeah oh no yeah you're so right you had like 8 person and then no 7 so we got the only and we can talk my and then I got like yeah I don't know what's going on yeah no it's I shouldn't be oh no I heard my yeah.
Aaron, hi, my name is Dr. Emmett. I am scheduled for an oil burner tune-up a week from today.
Yeah, so I did it, and that's where I'm like,
Okay, and I'm gonna have to cancel. I'm gonna have to cancel it because I'm going into surgery. The address is 218 Manhasset Woods Road, in Manhasset, New York, and my phone number is 516-312-200. And I guess I can schedule anywhere after the second week in September. So any day, second week in September, as long as it's not going to be the holidays. Andy, okay, we'll do fine again. No problem.
Like, we're so. I think of what I went for breakfast yesterday. I'm like, what did I eat for breakfast? Cereal. Yeah. Really for top off. I had one 24 years.
Be a problem. That's October 4th.
Yeah.
Okay, that was, I appreciate it. Thank you. Thank you very much. Thank you.
I would hear wrong. I know the answer. Okay, yeah, like one popular real person, like everyone. Literally, but now we like. You're like great. I'm thinking. Yeah, but you're still hard to grab. Yeah, I know. It's yeah. And I saw it like
I am, nobody's coming. Totally close. We don't know. Well, you know what the office looks like? No. I sold the building, they're coming with. The office got messed.
Yeah.
No, wait, who's gonna take those? First of all, you know any doctor who wants to work for Right. So that's what the issue is. So you got to find yourself a doctor and the rest of the recommendations. She
like sprayed into
they run right over. Okay. Time to find a big people doctor. Okay. Thank you very much.
She was like, okay, I guess, like, you know what, I found that, but I was trying to, I was like, my younger sister, I was a five, oh, yeah, my younger one, too, so I couldn't show you, but. Yeah. Let me sit down for a minute. Yeah. That's the thing, like, when you guys wrap it, I'm like, no, yeah, I like him crazy. I need it. Oh, a good round. Wait, I'm sure early. I have. Yeah, right. That's right. You're still worried about like. Yeah, I used to eat brunch for like I'm pro. No, like really? Yeah, when I'm like fully bread.
Okay, I'll be in the office at 12 o'clock. But I don't have to sign anything you do.
I was fine. I got nothing.
No, you have to. Somebody- Okay, so have to put my name on the first line, his name on the second line. Sign it. You have to give me permission to release the reference. Right, that's how it is. You put both kids next together. Okay, thank you.
I was looking this morning. Yeah. Maybe I should have it. I would. But yeah, found your family after like by now. Get over it. Yeah. I was there. Yeah, just not even. Well, you know what I meant is like mom went to for dinner. And I just brought up like an amputation. Oh. Like, he's like, I'm gonna no, you're not. No, like, I know you did. I just went to the park. You can go back. You don't have to. We have a family dinner. You gave like tilapia with ketchup. And I just mentioned the word amputation. Like, I like you about to like these kids. Oh my god. Oh my god. Okay, I'm with that. Yeah. Wait, show them half of the picture. Yeah. Yeah. Which one? Yeah. Oh, I know. Yeah, I know what you're about. You're talking. Yeah, it looks like yeah, I'm going like okay. Yes, yeah, and I'm like, thinking of picture wrong, like it was that was yeah. I don't know. You're like just so bad. Like is this just whatever? It's like oh my god, whatever. Which picture? Eyes girls like to see. Eyes girls like I want to see. Right? The ideal eye, said the guy. Yeah, one of the time where it's like, oh, this was fine. Like, yeah, your first lecture was. What am I so like? What? Good. I did not mind that. The piece is fine, but like there's no adding it. It was just library. And I'm like, I have to read the slides. Right. I think because it's like the practice like thing. Yeah. Yeah. I think it was like it took up time and then 90 seconds there. Like what is it elaborate? It was elaborate though. So like yeah. Or like whatever the slide says, that's what it is. It was dry. Yeah. Yeah. It's the material. Like the other lectures he explains. Yeah. Super nice. He's such a good guy. I found his baseball picture. I looked up. He went to high school with that and the comfort of Is you about to yeah. Guys, which one of us? Yeah. No, it's hard. Maybe it's broken, like, you know. No, it's not that kind, but like, well, honestly, it's not pick it up. Like, so there are lots of like honestly, if I was 32, I would just like for everything.
It is.
Also, I know I'm nervous about trying to like imagine.
Yeah.
Right. I love it. I went to the dog around. It always comes in. I can't. I love it. Like the other has to do so much. this costume is all right. Skip a lot of words. Yeah. Already. He's like, glaucoma, this is what you do for glaucoma. Yeah. We're dealing with it. Here's a list of all the medications I don't remember. I said I told them. Yes.
Yeah,
Right, we got. So,
I don't know if they listed.
Your lunch plan, that was really unhelpful. Yeah, it was not helpful.
Let's go, guys.
I don't want to take two. Yeah, to know first line, I'm like, I didn't hear line, thank you. Honestly, the only thing I remember is the truth is that. Yeah.
Okay, I'm gonna get started, because if I say 10 minutes, you take 20, if I say 15, you take 30, you know. We're gonna talk about short stature. Okay, and the only reason we talk about short stature basically is because there's growth hormone. Okay, and basically, most kids of short stature really don't need growth hormone, they're not growth hormone deficient. Okay, and it's very interesting, people's perception. Because when I sit behind, I examine a 2-year-old, I bring him into the office, and I say to the mother, oh, the 2-year-old son is going to be 5 feet 8 inches tall. Okay? And then their response is so short. And then I stand up from behind my desk and I say, excuse me? Okay? Because their perception of me has nothing to do with my height. Okay, none whatsoever. All right. So it's just very interesting. I mean, now that I'm retired, everybody's coming in and taking pictures of me, okay, with their kids. And every 10-year-old is taller than I am. I mean, I have some kids in my office. Well, it's like I'm in the forest. They're all standing around me. They're all up here and I'm down here, that kind of thing. So it's, height is a very subjective kind of issue here. Okay, so what's our definition of short stature? And short stature is defined as a child who's below the 5th percentile in growth. Okay, not below the 50th percentile, below the 5th percentile in height is a child who has abnormal short stature, or any child whose growth is crossing percentiles downward. In other words, they've been growing at between the 50th and 75th, and now they're below the 50th, and now they're below the 25th. These are the kinds of kids that we have to worry about. And when you're evaluating kids for short stature, you need certain information as to whether this is really a problem. Okay? So first you want to know how much does this kid weigh when they were born? Because if this was an SGA baby, a baby who was starved in utero, this kid is never going to follow the 50th percentile, regardless of what their parental heights are. So this is a problem. You want to know their growth velocity, and we talked about growth velocity in neonatology. The normal growth velocity is a newborn grows half its birth length the first year, half its length that they grew the first year, the second year, and then 2.5 inches a year till they hit adolescence. That's the normal growth velocity. So you really need to know what these kids' heights and weights have been doing. You want to know their height for age, their skeletal proportions, okay? Did they reach puberty? Didn't they reach puberty? And their bone age. Does everybody know what a bone age is? No. A bone age is an X-ray of the wrist. Because the bones of the wrist, okay, the carpal bones of the wrist, okay, ossify at different ages. So what you do is you send them to the radiologist to X-ray the wrist. The radiologist opens up a book and looks at the degree of ossification of the various centers, and you'll get a report that the kid is a chronological age of 10, but a bone age of 8. So you know that based on the book that this kid is 2 years behind in their growth, and they have room to catch up. If the chronological age and the bone age are the same, this is the kid whose bone age is normal for this particular height. So what's the etiology of short stature? Well, the most common cause of short stature, okay, is major organ system disease. Okay, this is the largest category of poor growth. And again, if they have major organ system disease, you should be able to make the diagnosis by a good history and physical exam and maybe some blood work. But if you go through the parameters, their birth weight is normal, okay, was normal, and their growth velocity, height for age, skeletal proportions, onset of puberty are all abnormal or decreased, and they're decreased because they have major organ system disease. Okay? If a child has a chromosomal disorder, okay? Well, these are the funny looking kids. You know there's going to be a problem with the skin. Turner syndrome girls are all shorter than normal. Fetal alcohol syndrome, shorter than normal. Down syndrome kids, shorter than normal. Okay? And you should know that Turner syndrome in females is as common as growth hormone deficiency. So once again, these kids' birth history is normal, and then all the other parameters, growth velocity, height for age, skeletal proportions, onset of puberty and bone age are all decreased. Then we talk about the SGA babies, the kids who are starved in utero or have some intrauterine process going on, like genetically transmitted somatic disorder, deficiencies, okay, cystic fibrosis, metabolic bone disease, they are going to be smaller than normal, okay, or extrinsic causes like nutritional deficiency, the mother starved in utero, the baby's going to be SGA, ingestion of cytotoxic agents like cigarettes and alcohol will cause small babies, chronic maternal disease, and torch. And when we talked about these babies with SGA, we talked about these are the kids who have slower cell divisions, and then when they're born, the total number of cells in their body are 60 to 70% less, are 60 to 70%. So they're 30% less than what it should be. So of course they don't have the extra amount of cells to reach their genetically predetermined height. So when you look at these kids, they're thin, they have minimal body fat, okay? They have narrow faces. So their birth rate was decreased. Because they have fewer cells, their growth velocity is decreased. Therefore, their height for age is decreased as well. But their skeletal proportions are normal, their onset of puberty is normal, and their bone age is all normal, except their final height is shorter than normal. Then we have familial or short stature. This is a common cause of short stature in children. Okay? The parental heights are lower than normal, so their kids' heights are going to be lower than normal. So if you have a child who's growing at the 5th or 10th percentile, put the father's height and the mother's height on the growth chart. And if the kid is growing between the two parents, okay, then you know the kid is following the growth of the parents. You know, 2 5 feet tall parents are not going to make the next NBA basketball player. It just doesn't happen that way, okay? Now, occasionally you have a short parent and their kid exceeds the calculations, and we'll go through that in a minute about how you figure out what the hell's going on with this kid. You know, you do the calculations, the kid should be 5'8", the kid's 6 feet tall. What's going on? It doesn't make any sense. Yes, it may, and we'll talk about that in a minute. Okay? So that's familial short stature. Then we have the constitutional delay. Okay? This kid, instead of growing 2.5 inches a year, is growing 2 inches. So by the time he gets to high school, okay, you know, high school at what? He high school at 13, 14 years of age, okay? For 10 years, he's been growing a half an inch shorter every single year. For 10 years, he's 5 inches shorter than all his peers, okay? And because he's 5 inches shorter than all his peers and he's growing slower, his puberty is delayed as well. These are the kids that, and they're mostly boys, and these are the kids we have psychological problems in high school because they're 5 inches shorter than their peers. They haven't developed their secondary sex characteristics. They all look like they belong in junior high school rather than high school. And then we have psychological problems because they don't want to go to the gym. They can't have the gym and change their clothes. They won't want to keep up in sports with their peers because they're smaller than they should be. But if you take a family history on these kids, somebody in the family, okay, because this is a constitutional delay, okay, had an uncle or somebody who continued to grow in college. In other words, he was short, he was short, he was short. He had, when he was a high school senior, he started to grow, and now he's 6 feet tall. Okay, you do the calculation. These kids have a constitutional delay. It tends to run in families. Okay, and basically they're behind. Their bone age is delayed because they're behind. Their puberty is delayed. Basically, their birth weight is normal. Everything else is delayed, but their final height is absolutely normal. It just takes them longer to get there. Okay? Do these kids need growth hormone? Probably not, unless it's a major psychiatric problem, and then you give them the growth hormone. But the side effects of growth hormone are not benign, so we'll talk about that in a minute. So that's constitutional delay. Endocrine disorders are the least common cause of short stature, including growth hormone deficiency, hypothyroidism, okay, um, cortisol excess. Again, hypothyroidism, you should be able to diagnose clinically, okay, because these kids have interskeletal proportions, their bone age is delayed, and their height is shorter than normal. That's the hallmark of hypothyroidism. Growth hormone deficiency is usually idiopathic, okay? And again, the only way you're going to diagnose growth hormone deficiency is to screen for it, but generally, you only screen for it in the kids that you've ruled out everything else, and cortisol excess. But if you have cortisol excess, you have subnormal linear growth, but you also have a delayed bone age, cushingoid features, buffalo hump, moon facies, okay, centripetal obesity. They're going to look cushingoid. So you're not going to do growth hormone. You're going to screen them for cortisol excess. So again, everybody who's short stature does not require growth hormone. Skeletal dysplasias, achondroplasias are shorter than normal, okay, and psychological factors may be involved. So how do we work these kids up? Okay, number one, you want to rule out chronic disease. So you do a CBC, a urine analysis, a SED rate, a metabolic profile, urine culture and sensitivity, T3, T4, if you suspect hypothyroidism, bone age, X-ray of the wrist, and karyotyping for females to rule out Turner syndrome. Okay? And if all of these are normal and the bone age is delayed and you have no other etiology as to the possibility of what the possibility of short stature, maybe you want to do a growth hormone. The only problem with growth hormone is your mother was right. The more sleep you get, the taller you're going to be because growth hormone is secreted at night when you sleep. So the only way to get adequate growth hormones on kids is to go to the house at 2 o'clock in the morning and draw the blood there. And obviously nobody's going to do that. So how in the world do we get an adequate growth hormone? We do stimulation tests, okay? Which means they go and they get an IV infusion, and the things that can stimulate the secretion of growth hormone is L-DOPA, insulin, arginine, clonidine, and glucagon. Those all will secrete growth hormone. And in order to get the insurance companies to pay for it, you need two stimulation tests to be abnormal. So if you do one stimulation test and the result is less than 10 micrograms per deciliter, that's a positive growth hormone test. The second one has a 50% chance being higher or lower than the first. So if your growth hormone level is 9 and the second one is 11, you're not getting growth hormone. You need two significantly negative tests in order to get growth hormone. Okay? And growth hormone is about $2,000 a month for 2 years of injections. Okay, that's when you're in college, basically. So that this becomes a problem. Now, there are some people who insist on giving themselves growth hormone. Okay, we got to give it to him because my kid is not going to be successful unless he's 6 foot tall and he's only going to be 5'8". Well, too bad. Growth hormone only is about 2 inches, at best. Okay, so you know, talking to these patients is like my parents like talking to the wall. Okay, but there is a side effect. Okay, and the biggest side effect of growth hormone, okay, is it increases the risk of developing type 2 diabetes by 8.5 times. Okay, so yeah, your kid will be taller, he'll be fat, and he'll have type 2 diabetes if that's what you really want to do to your kid. Okay, because that's what growth hormone can do. Besides increasing insulin resistance, which leads to type 2 diabetes, risk of pancreatitis, pseudotumor cerebri, slip capital femoral epiphysis, okay, worsening of their scoliosis if they have it. All the risks are giving to developing, to getting growth hormone. So once again, we really don't do that. I discourage it. Let's put it that. Okay. Now, when you're calculating the final height, okay, the easiest way to do the calculation is to double a boy's height at 2 and double a girl's height at 18 months of age. And that's the final height. I think I went over that in neonatology to prove it. I mean, think about it. A 20-inch baby is 30 inches at 1 year of age. So you do half of his birth height. And at 2 years of age is 35 inches. And you double it, that's a male height of 5'10". That's the average male height. And the female, the 20 inches at birth, 30 inches at a year of age. At 18 months, it's only 2.5 inches. Okay, so that's 32.5 inches. Double it, that's 5'5". Average. It works. But then we have the mid-parental height calculation. So if we're talking about male boys, okay, basically you take the father's height plus the mother's height plus 5 inches, and you average. And that's the mid-parental height calculation for males. That's how we calculate. For females, okay, you take the mother's height plus the father's height minus 5 inches. And that's the mid-parental height for girls. Okay? So, I have a father. He's 72 inches tall. Your mother, okay, is 65 inches tall. So I do the calculation, okay? I subtract 5 inches from daddy, okay? That's 67 and 65. The son should be 5 feet 6 inches tall, right? That's how you do the math. Their son is 72 inches tall. The math doesn't work. You're wrong. How in the world did you do this calculation? It doesn't work. There's just one problem. And the problem is right here. Okay? This mother's mother smoked and drank during her pregnancy. Okay? Her mother was 68 inches tall, and her father was 72 inches tall. So they had to subtract 5 inches from her daddy and average with her mother. She should be 5'8", but she was SGA. Okay? Because of what her mother's smoking and drinking. Well, if she's 5'8" and she's 68 inches tall here, and I add 5 inches, the math works. So if the math doesn't work, you should do the mid-parental height calculation of one of the parents, because they may have been SGA, and then the height. So that's where I told you when you do the mid-parental height calculation, why it doesn't work? Because one of the parents are shorter than they should have been for some reason, but their genes are the same, so the genetic influences haven't changed. Okay, so that's basically how we do the calculation. Now, growth hormone was first approved for growth hormone deficiency, okay, in basically 1985, okay? In 1996, it was approved for girls with Turner syndrome. In 1993, it was approved for chronic renal failure. In 1997, it was approved for achondroplasia. For small to date babies, it was approved for 2001. But my notes list a whole slew of other patients, most of these basically with major metabolic illnesses where growth hormone has been approved for use. So, who are the companies looking to increase use of growth hormone to? Who are the people with all the money that can afford growth hormone? What population of all can afford growth hormone more than anybody else? What? Old farts like me. Okay? Because giving old farts growth hormone increases muscle mass. Okay? Increases muscle mass, increases, muscle density and what have you. So it's great. I mean, you give it to the old people, their muscle mass improves and everything else. Except for one slight problem, and what's that? What?
Maybe everything grows.
Like what?
Organs.
Not organs.
Spring.
If you have a malignancy and you give growth hormone, guess what happens to the malignancy? The malignancy grows as well. So if you go out to California and you ride the highways, you'll see ads, okay, for total body MRIs. Because if you're going to do growth hormone, first you need a total body MRI to prove you don't have malignancy anywhere. So then you can take the growth hormone and increase your bone density and muscle mass. Okay? Because that's who they're pushing it to, at least in California. And where all the wealthy, beautiful people are, the more growth hormone you take, the more beautiful you'll live forever. And now the latest thing to get you to live forever, and the latest push for living forever is peptides. Okay, that's the other thing that everybody's pushing. There's a peptide for everything. For hair gain, I mean, you name it, there are peptides. And none of them are approved. Okay, all of them are being made by pharmacies. They're not made by major drug companies, but that's out there. You're going to find people who are on peptides also. This is the latest craze that's out there on the internet for staying healthy. But I don't know how to break it to you. You're all going to die. Okay? Eventually. Hopefully you live a long life, but you're all going to die eventually. None of you are going to live forever. Okay? And that's how I get into this conversation on death and dying. Because when I was an intern, okay, before my residency, I took a rotating internship, and a patient would expire, okay, and you call up the local doc, Dr. Smith, Mrs. Jones, your patient just expired. Thank you very much. Call the family and notify and get consent for an autopsy. What? I don't know these people for a hole in the wall, and you want me to call them and tell them that their loved one died and ask them for an autopsy? What are you, out of your mind? But that's how it went. Because in medicine in the dark ages, if a patient died, you failed. You were supposed to keep a patient alive forever. Okay? You weren't allowed to people dying. Now, that attitude has changed in medicine over the years. Our attitude towards medicine has changed. Okay? But the reason we don't talk about death and dying is it makes us uncomfortable. So here's my question. How many of you have a medical directory? None of you. Nothing's ever going to happen to you. You're all adolescents. You're never going to get into an automobile accident where you're brain dead and you're in a vegetative state and you're going to cost your family $110,000 a day to keep you alive in the ICU when you're brain dead. Okay? because none of you have a medical directory. You can all be like Terry Schiavo. You know who Terry Schiavo was? She was a young woman in Florida in her 20s who was declared brain dead, and the governor of Florida decided her husband wanted her to turn off the support system. Her parents and the governor of Florida decided they should keep her alive because. Then this decision is going to be made for you. I'm sorry. You don't have a medical director, that's what's going to happen to you. But here's what's worse. How many of your parents have a medical director? You have no idea because you haven't asked them. Okay? And if you can't have the conversation with your parents, how are you going to have the conversation with your patients who you know are terminal? And you have to say, will you please tell me, what do you want me to do when the inevitable happens? Do you want to be kept alive at all costs? If you're brain dead, I mean, do you want us to, give IV nutrition, everything else to keep you alive? Or if you're beyond all hope, do you want us to let you die? If you can't do that with your parents, how can you do it with your patients? And the next question. You know you don't have a will, because if you don't have a medical directive, you definitely do not have a will, okay? Do your parents have a will? Yeah, you know where it is? Right. That's the next problem, okay? So they have a will and you haven't a clue where it is, okay? This is the problem, okay? You're all comfortable having this conversation, but it's one you have to have, okay? My mother had gallbladder cancer, liver mets. We kept her at home until she died, and I didn't think I could fill out a death certificate for my parents. Apparently I could, but I didn't think I could. So I had a friend of mine, okay, because you all want to die at home. I mean, that's where you all want to go, in your own bed. That's everybody's fantasy, okay? So I had a friend of mine fill out the death certificate, and he made a mistake. I said, fill out the death certificate, just leave the date blank. When she dies, then I'll have death certificate. You call the mortuary, off she goes, no problem. He made a mistake. I didn't think I could fill out the death certificate. So if you die without a death certificate, you know what you are? You're an ME case. And unless the medical examiner clears you, you can't bury the person. Okay? So I called 911. I said, I need to speak to them. I called the medical examiner's office. The medical examiner, my name is Dr. Emmett. My mom just passed. I need his clearance. They kept call 911. So I said, my name is Dr. Emmett. I need to get a hold of the medical examiner. What's the matter? My mother just died. I have to get consent. Okay? In 5 minutes, 2 police cars, the ambulance, and the fire department arrived. Okay? Now, my parents lived where I practiced, so I know half the cops because I was taking care of their kids. So it wasn't an issue. They had to sit 2 cops in the house till the medical examiner got around to calling, till we got permission to release the body. Okay? So if you don't have somebody to fill out a death certificate and you die at home, you're in real trouble. Okay? So that's number one. Okay? If you don't have a will, I'll tell you what they do. You're intestate. So the government locks up the house. And they don't let you into the house until you go to court to determine who's responsible. And if the cemetery plot is still in the house, you got real problems, because then you can't open the cemetery to bury the person. So these are all the issues that come up when we talk about death and dying that nobody thinks about, because nobody wants to talk about it. Okay? And then the next question is, okay, grandpa dies and you have kids. At what age do you take a child to the funeral? What age do you bring kids to the funeral? I'm open for ages. Anybody? 10? Okay, anybody else? Chicken? Huh? 3. And I'll prove it to you in a minute. Okay? You know why we don't take kids to the funerals? In the bad old days, people died at home. Death was normal. Okay? Grandpa was upstairs dying and everybody was downstairs. This was normal. Now we sanitize deaths. You die in the nursing home, you die in in the hospital. Nobody dies at home. So death all of a sudden has been removed from natural life and living. Okay? So this is what happens. So you can take 3-year-olds to funerals. Okay? Why don't we take 3-year-olds to those? Because they make us uncomfortable. Okay? That's why we don't take them. They may ask us questions that make us uncomfortable because we're not comfortable talking about death and dying. So then the next question is, how do we introduce dying to children? Okay? I mean, how do you introduce the concept of death and dying to children? Okay? And we do it with books. When I started doing this, the librarian at my local library, because the only books I was looking at was of death and dying. If you don't want to talk about animate objects, live objects, okay, you can talk about the death of Freddie the Leaf, okay, written by a psychologist, okay, and basically it's a book about, Freddie the Leaf. He had grown, he was large, his midsection was wide, he had 5 extent, big, healthy leaf. Okay, yeah, that's Freddie the Leaf. And then guess what happens as he lives? It's fall. Okay, leaves change. Okay, well, all the leaves became frightening. What's happening? They ask each other in whispers. Okay, what happens is it's what happens in fall, Daniel told them. It's the time for leaves to change their home. Some people call it to die. Okay, and Freddie don't want to die. Okay, that's Freddie. He's stuck on the tree. He ain't dying. Okay, but obviously he goes. He was the only leaf left on the branch, okay? And then the snow came and he started to fall. And as he fell, he saw the whole tree for the first time, how strong and firm it was. He was sure that it would live a long time, and he knew he had been made a part of his life and made him proud. Okay? So now we have the whole story of death told through a leaf. You don't have to deal with animals. Okay? This, okay? The dead bird. Okay? There are kids who have parakeets, and the parakeet croaks, or the canary croaks, and the mother dumps out the bird, goes to the pet shop while the kid's at school, gets another bird and puts it in the cage, and thinks the kid doesn't know what they did. Of course they know. Kids are smarter than we think they are. Okay? If the bird died, you had a perfect excuse to go through the conversation of death and dying. That's what happens to people and birds and animals and everybody else. So here's the dead bird. Okay, there it is. The bird is dead. The bird was dead when the children found it. Okay, it was. They found it. It was cold. It was limp. It wasn't dead for long. Okay, they looked for a heartbeat. It wasn't there. So they decided. Okay, they were going to have a funeral for the bird. They were sorry the bird was dead. It could never fly again, but they're glad they had found it because now they could dig a grave in the woods and bury it. They could have a funeral and sing to the way grown-up people did when someone died. So there they go out to the woods. Okay, they dug the hole in the ground. There it is. They wrapped the bird up. They put ferns at the bottom of the grave, wrapped the bird up. Okay, they had a funeral and they put flowers on the grave and they sang a song to it. Okay, children's book. This book I use all the time. The 10th great good thing about Barney. Barney was a pet cat and the cat died. Okay, and how they dealt with the death of the cat, okay, was they went through the 10 good things that they remembered about the cat. And I had a kid in my practice, came in totally depressed. His dog Oreo died. Okay, so take this home and read it. Okay, and it got him into a conversation with his family about the death of the dog and how everybody felt, and got them to deal with the concept of death and dying. Okay, does anybody know who Elizabeth Kubler-Ross is? Elizabeth Kubler-Ross wrote the book on death and dying with the 5 stages that people go through when people die: denial, anger, okay, bargaining, depression, and then acceptance. Those are the 5 stages. I met Elizabeth Kubler-Ross, okay? The only person I know shorter than me, she's not this big, okay? She was giving a lecture to the American Academy of Pediatrics on death and dying. And she happened to be a very spiritual person. And as she was talking about how when kids, I can tell you that if you're in the hospital with a terminally ill kid and the kid says, I'm going to die tonight, you can sit in that room with a crash cart and the kid's going to die no matter what you do. Okay? They know. How the kids, I have no idea, but Elizabeth Kubler-Ross said she would know from the drawings and the paintings they made over the months that they were terminal and right before they died. They changed, and she could tell right before from the artwork that they did that the kid was going to pass the next day or so. Half the pediatricians in that lecture left the room. They did not want to hear about it in this day and age. Okay? So this basically is a real problem to deal with, okay, when you deal with kids who are terminally ill. Okay? Another way to deal children's book, how many people read this book? The Bridge to Terabithia. Okay? This book won the Newbery Award for the best children's literature in 1977. It's a story about a boy and a girl. The boy is a country boy. The girl comes from the city, moves out to the country, and the two of them have this fantasy land, Terabithia, and they're the king and queen of Terabithia. They become very close friends, and then one day, the teacher at school takes the boy to the museum. He forgets to tell the girl that he's going to the museum with his teacher. She goes out looking for him, trips, falls, and breaks her neck and dies. And then this boy has to deal with the death of his best friend, who he could have prevented it by telling him he was going away and wasn't going to be where she expected. Okay? It's a best book of children's literature. It didn't win the award for death and dying. It won the award for being the best children's literature of that year. There's also a movie that they made of it, which isn't as quite as good as the book, but it's a remarkable book. Okay, so these are some of the books that are out there that are using death and dying, but this is the one I use. It's obvious on dying. Okay, so I have multiple copies of this in hard and soft cover, and I give them out. Okay, and guess who we're going to talk about? We're going to talk about a bird. Okay, Snow. Okay, now he was live to fly. Jane and Eric hold him in their hands, loved him. Big bird letters for kids, small letters for parents to anticipate questions that may come up and how to answer the questions that may come up. And guess what happens? Okay, the bird is dead. There we go. His head felt a little too loose. His body was stiff. He was cold. He didn't move anymore. He was dead. Okay. Eric felt like keeping Snow. He was interested in dead animals. Mom said, it was Snow awful. It was time to bury. So guess what? They have a box. They wrapped him in a handkerchief. Friends came to see him too. And they had a funeral for the bird. Well, if you have a pet, like a bird, and the pet dies, why not have a funeral? It introduces the kid to what we do when somebody dies. Okay? And then the bird was dead, but the flower was alive. Did you notice anything? This is the first colored picture in the entire book so far. Okay? Okay, then guess what happens? Okay? We got Snow. Grandpa gave it to us. This was Grandpa who gave children Snow, took pictures with them. You know what's going to happen to Grandpa, right? Grandpa gets sick. Okay? Be quiet. Grandpa was sick. Okay? And then Grandpa died. And Mommy was crying. Okay, well, that's normal. Okay? Like the dead bird, he was put in a box called the coffin. He wondered what it looked like. He wanted to keep the coffin with Grandpa in it. But no, they went to the funeral. They had a funeral. Okay? At the graveyard, it was buried. Okay? But Michael took a lot of grandpa things and ate all his cookies too because he still felt empty inside. Isn't that what happens when we lose somebody or somebody dies? Or his sister, on the other hand, was mad at grandpa for dying. She teased and tore things up. She cried and cried. She played making graves for dead bugs, made beds for them to sleep in, okay? And she knew they were dead. Then one day it was rainy, and Eric said, "Why do only men have black umbrellas? People wore black when Grandpa died. Black made Eric worry about dying." And there's the next colored picture in the book. He asked Mommy, "Can I have a red umbrella?" Because a red umbrella made him feel safe. Okay? So I have a family who calls me up. Grandpa died. Do we take the kids to the funeral? 3-year-old and a 5-year-old. Yes, you do. Okay? And I gave him the book. Okay? The rabbi was really a smart guy because he asked these two kids, "What should I say about your grandpa?" So at the funeral, these kids were very well behaved. Why? Because that guy was saying what we told him to say. Okay? They go to the cemetery, and I'm not saying you drag kids to cemetery. You offer them, "Do you want to go?" Okay? But what is a cemetery to kids? It's a park. It's a big spread out area with trees and gravestones and what have you, a great place to run around and play hide and seek. They're not being disrespectful. They are being kids. Okay? So they come home, and during the Shiva, okay, Mommy is playing either Candyland or Shoots and Ladders. You know, the board games that you grew up with. I don't know. Okay? And the 3-year-old picks up the red piece and hands it to his mother and says, "I want you to be this color." Tell me that that kid did not know or get the concept of death and losing a parent and feeling unsafe. And that's why you can take 3-year-olds to funerals, because 3-year-olds get it appropriate for their age. So yes, we take kids to funerals. Okay? And the 4th funerals, hopefully we can introduce them with certain books on the concept of death and dying. If you have the opportunity and a pet dies, have a few, even if it's a goldfish and the fish dies, have the opportunity. Okay, the fish died, we're going to bury the fish. Okay, it gets them used to the concept instead of being afraid of it like you all are. Let me ask you a question, okay? I think I told you in the lecture that I had a patient of mine die in an illegal daycare fire in one of my first lectures. Did I tell you that story? So when I heard it, I had my secretary call, and I found out where the funeral was, and I went to the funeral. And it was a Seventh-day Adventist funeral. Okay, they were African Americans. I was only the only white face in the whole funeral. And I walk in, and they say, "Thank you for coming. Would you speak?" And what are you going to do? Say no? You're going to run for the hills? Okay? Or you're going to open your mouth and figure out something to say. Well, if you're not comfortable with the concept of death and dying, you're not going to be able to do that. Okay? And that's why we're having this lecture, because it's time for you to start thinking about the concept of death and dying. And if you can't have the conversation with your parents, you're doomed, because then you're not going to have to be able to do it with your patient. Now, some of you will not be in an environment where you're going to have the opportunity to ask, but some of you will. And if you know a patient is terminal, okay, and I'm not saying terminal is going to die tomorrow, but he has an illness, like he's got cancer, and the treatments aren't working, okay, he's going to die down the line. Have you made arrangements? Does your family know what you want? Do you know what you want? That's the conversation you need to have with your patients. Now, I did things you're not supposed to do in medicine, okay? I told you about my first patient, Michael, who was diagnosed with leukemia. When Michael was diagnosed with leukemia when he was 5, okay, fever of unknown origin, was diagnosed with leukemia, went off to Sloan. And he was being treated there. And do you know what happens in families where there's terminally ill children or significantly ill children, the divorce rate goes up. And I saw the mother one day, and in my best medical terminology, I said, "You look awful. What the hell's going on?" I knew what the hell was going on. Okay, the parents stopped talking to each other. I said, "Look, Michael's home from the hospital. Nothing's going to happen in the next week or two. Grandma's here. The two of you need to go away for a weekend, okay, and start talking to each other." And they did. They listened to me. Okay. And then when they came into the office, Mom was still having issues because Michael wasn't doing well at Sloan. Okay. And they would have parent meetings talking about how wonderful everybody was doing. And she would raise her hand and say, "What about the kids who aren't doing so wonderful?" Okay. I will talk to you later because they didn't want to move there. So I said, "Listen, anytime you need to talk, show up any day after office hours. I'll sit and listen. You don't need an appointment. Just come in any day and I'll sit and listen." Okay. Well, after 2 years of therapy, Michael wasn't doing too well. Okay. Nothing was working. And at 7, Michael said, "Enough is enough. I'm done." And the father said to me, "If he codes, anybody comes in and tries to resuscitate him, I'm going to kill him." So I said, "Well, do you want Michael to die at home?" "Yes." "All right. I'm willing to do it, but here's the potentials of how we die at home. I'm willing to work on it, etc., etc." They said, "Fine." They brought Michael home. December 15th, 1985, I get the phone. So I go to the house and start a morphine drip. They call me back at 2 o'clock in the morning. He died. I went, I filled out the death certificate, called the mortuary. They went and picked up Michael. Okay. No ME case, nothing. He had died. Okay. So obviously, Mom was pregnant. And I don't know why I said this. I have no idea why I said this. It's December 15th. They were Roman Catholic. I said, "I'll see you Christmas Day." John was born Christmas Day. Don't ask me why I said it. No idea. And John was exactly like Michael, so we both had a good cry. John is what, 45 years old now? Okay. Remember the family about Hirschman's disease and thyroid carcinoma? That's John. So John had his thyroid removed. His daughter, who was 5, had a thyroid removed. Okay. This is the family with poor genes. And in fact, Daddy smoked like a chimney. Okay. Despite the fact that I yelled at him. Okay. John's father. And he developed lung cancer. And I pronounced the father at home too, and he died and filled out his death certificate. So this is you can't not get personally involved when you have this. So after Michael died, about a year later, Mom calls me up and says, "What are you doing an unveiling?" Because I had an aunt who died, and in the Jewish religion, you put the stone up 11 months after, the funeral. So I told her. She says, "Well," they said, "it's a year from since Michael died. Are you planning to have a memorial service?" She said, "Yes." And you want me to lead it? Would you? So here's a Jew in a Roman Catholic cemetery leading a memorial service for him. So this is how I've dealt with it. Okay. I've opened myself up. I mean, I've gone to funerals, not of my patients, okay, but of grandparents that I knew and of patients and what have you. And basically, I'm there, and half my practice is there. I live in a community of a lot of Irish Catholic. They got lots of kids. And when Grandma dies, and I go to pay her my respects, the funeral parlor is right next door to my office. Okay, so I go and pay my respects. Half my practice is there. I am comfortable with the concept of death and dying. Okay, I'm comfortable enough giving this lecture because I want you to be comfortable, because otherwise you're going to be very uncomfortable in medicine. Okay, no matter where you go, you're going to find people who are going to be termed, even in dermatology. We say about dermatology, they never kill anybody, they never cure anybody, they just keep bringing them back. And yeah, unless you got a melanoma and you're ready for death. Okay, so this is the issues that you're going to deal with. So that's why I always end this lecture with this, because it's something you have to think about. And if you can't have the conversation with your parents, okay, then you're in real trouble because you're never going to be able to have it with your patients. So that this is the message that I give you. And kids are more resilient than you think, okay? They can deal with it. Now, there's one last book. How it feels when a parent dies. And she interviewed kids from around, I think, 7 to 16. Okay? And obviously, if you go through all the things, the biggest fear is what happens if my other parent dies. That's obvious. Okay? But what are the other things going on? Okay. You go to pay a condolence call. Remember your first condolence call that you ever went to? Or haven't you gone to a condolence call? I first started giving this lecture when I was teaching in a medical school. And I said, anybody here who has never gone to a funeral? And half the people raise their hands. That's scary. Okay? You're going into medicine and you've never been to a funeral and you're at this stage in your life, somebody around you has died. You never made a condolence call. Of course you don't make a condolence call. What am I going to say? What am I going to do? Well, to tell you the truth, you don't have to say anything. You just have to show up. That's the only thing you have to do. To show up and give support. There is really nothing you can say. What are you going to say? I know how you feel? No, you don't. Okay? Unless you lost somebody, you don't know how they feel. So you just show up for your support. But it's uncomfortable. Okay? It's uncomfortable to pay a condolence call. You feel awkward. You don't know what to do. Well, guess what? What if you're a friend of these kids whose parents have died? One of their parents has died. Is it catching? Do I go and pay a condolence call? Maybe my parent will die if I go to pay a condolence call. Or if I associate with this kid, maybe it's catching. This is how kids think, folks, okay? So one of their biggest complaints is they're losing their friends. The people who were friends begin to be afraid of associating with this kid because their parent died. So if you have a kid who loses a parent, the first question you start to ask is, how are you doing? And what's the story with your friends? Because nobody's asking that question, I guarantee. Okay? And these kids all feel abandoned by their friends. So it's bad enough that they're losing their parent, now they're losing their friends. So first, you ask the question. Now you have an acknowledgement of what's going on, because now there are websites where kids who lose parents can go online and talk to one another. So there's a community of kids who have lost parents who know what it feels like. But if you never acknowledge it, okay, the kid feels abandoned by you too if you're the clinical provider, because you're not even asking the question. Here I am all alone. My parents gone. My friends are abandoning me, and you're not even asking the question. So these are the things I want you to think about, because this is the real world. This is what goes on, okay? And you're going to be exposed to it whether you like it or not, either in your own families or in your practice or whatever. It's going to happen, okay? And you never want to go to a funeral and have somebody ask, would you speak? Okay? Because you can't turn and run, okay? And now you're really stuck, all right? And I wish you good luck from here. Good luck in all your exams and your practice, okay? I'll probably run into most of you during callback or what have you. That's what I wonder when you get called back. You'll be called